Hello, Dr. G. Ellis, licensed pharmacist here. I put together this presentation on ADHD for family medicine residents, and I'm going to share it with you today. It is meant to be interactive, so feel free to pause the video at any time to answer the questions and participate as if you were in the audience. So let's go ahead and get started. This is my disclaimer that this is meant for informational purposes. You should always speak to a provider before any medication changes. I have no affiliation with any of the companies I will talk about in any drugs today. So to start, how do you decide treatment for ADHD? What variables do you consider? So pause this video, think about it for a few moments, and then come right back. So you want to consider the patient's age, and that will determine what appropriate first-line treatment is. Any concomitant conditions like substance use or tics. Tics are very common in conjunction with ADHD. And then other variables is the formulations that are available to the patient, whether they can swallow tablets or capsules whole, or whether they can only do chewables or patches. And then of course, cost and insurance. If the insurance doesn't pay for it and they can't afford it, they cannot take it. And then another variable that we will talk about in more detail is how long the formulation works for. So SR, ER, LA, etc. There's patches, suspensions, osmotic release, prodrugs. How do you keep them all straight? Well, unfortunately, there is no standardization for what these things mean. So it's really going to be on a product by product basis in terms of whether the SR or the ER is longer and how long that means. But we'll go over some of that in this slide presentation and give you some additional insights. So a case, Jack, 5-year-old, he has past medical history that's positive for eczema, that's currently treated with crisaborole. Eucrisa. Father reports that his difficulty sitting still, he forgets things for his kindergarten class, and his kindergarten teacher Calypso reports that he has similar behaviors in class where he will not be able to sit still and he'll interrupt his classmates when speaking. So Jack's father and Calypso fill out a Vanderbilt, which corroborates a diagnosis of ADHD. Jack has difficulty swallowing pills, but he's successfully taken amoxicillin suspension. And his kindergarten class goes from 9 to 2. Mornings are chaotic. He wakes up at 7 and leaves for school at around 8:30. So my question for you is, look into one of these medications and see if it'd be an appropriate choice for Jack. As I said, this was an interactive session, so take a 5-minute break to look into one of these drugs and see if you feel it'd be appropriate for Jack, why or why not. And ideally, if you could be able to counsel Jack and his father on its use. Now, I put here that the patient has CareSource, which is our local Medicaid. So use that as a starting point. So one of your options would be Astaris or Zelstrim or Quellbri. So take 5 minutes to review and come back to the presentation, decide if you would use it for Jack. So what did you decide and your agent? Would you use it for Jack? Why or why not? We'll come back to that. So Astaris is sir-dexmethylphenidate and dexmethylphenidate. Zelstrim is dextroamphetamine and Quellbri is viloxazine. So we'll come back to those agents in a moment. Broadly, there's 2 general classes of stimulants. We have the methylphenidates and the amphetamines. So we'll start with the methylphenidates. There's the IR versions like Ritalin, Methylin. They have about a 30-minute onset and they have a duration of 3 to 5 minutes. As you know from patient care, there's going to be a range of how long these last for your patients. There's a multitude of long-acting formulations, Metadate, Concerta, Contempla, XR-ODT. The ODT is nice if they can't swallow like Jack. And then the long-acting can last 8 hours for the Metadate, 12 hours for Concerta, etc. And I do have tables that are a nice summary of these different formulations so that you could reference them for yourself later in the presentation. Additional methylphenidate options. So there's Focalin, Metadate CD, which is different than Metadate ER. And generally speaking, with the stimulants, the long-acting formulations are mostly formulated so that they act like an immediate release plus longer acting. So they work pretty quickly, and then depending on the formulation, they can last up to potentially 12, 13 hours. So the Astaris is a prodrug. The sur-dexmethylphenidate is converted into dexmethylphenidate, and that makes it act like a long-acting formulation, and it can last up to 13 hours. There's more. So there's Quilivint, Quilichew. They act within an hour. The Quilivint is a suspension, and the Quilichew, not surprisingly, is a chewable tablet. The Daytrana, that is the patch formulation. What's nice about that is you can control the duration that it lasts by taking it off. And so you want to take it off about 2 hours before the intended end time, but it should not be cut. Astaris, let's talk about it in more detail. So I already mentioned that the sur-dexmethylphenidate is a prodrug. It was recently approved in 2021, so that's why I chose the 3 agents that I did, because they are more recent approvals. It's used for children greater than or equal to the age of 6 and adults. What's nice about it is it can be sprinkled into water or applesauce. And then one thing that I wondered about when I put this together is, with it being a prodrug, it might be a nice choice if a patient has a substance use history, because it's not an active ingredient. And I put that's kind of Vyvanse's claim to fame. It's harder to abuse because the ingredient is not an active formulation. It has to be converted to the active form. Right now, switching to the amphetamines, there's a multitude of these as well. Similar to the methylphenidates, they work pretty quickly. There's sustained release like the Adderall XR, and there's the Vyvanse, the lisdexamphetamine that I talked about a moment ago. It can act up to 10 hours. There's the ODT formulation and the XR formulation, and then Zelstra, which is dextroamphetamine. So Zelstra is to amphetamines what Daytrana is to methylphenidate. So Zelstra is a patch, which again is pretty nice. Now, one thing that's different about Zelstra is it's approved for children and adults, whereas Daytrana is for children only per FDA approval. And also it tends to have less skin reactions with the Zelstra compared to the Daytrana. As a general principle, you want to use methylphenidate for children and amphetamines for adults. And we'll come back to that in part 2. And then Qelbree. So Qelbree is recently approved in 2021. It's a non-stimulant. So it's similar to Strattera. It's a selective norepinephrine reuptake inhibitor. So it doesn't work immediately, which is one of its pitfalls. It does tend to work faster than Strattera, as early as 1 week. And then in studies, it's been much preferred over the atomoxetine over Strattera. However, with it being so new, not all insurances are going to want to pay for it. This one can also be sprinkled on applesauce or pudding. So these are nice summary slides that go over the different formulations, and it has the different brand names, different doses. The first one is crossed out because it doesn't it's not being made anymore. But you can see how the duration changes, the formulation changes. One I will point out, the Journey PM. What's unique about that, the reason it's called PM, is you take it the night before and it's formulated so that it starts working the following day. And then the arrows are what were specifically on formulary for Jack. And so you can see that they do cover a fair amount, but not all of the different formulations. And here's the amphetamines, the same idea as before. And the arrows are what the Medicaid in our area pays for. So you can see that it doesn't pay for Adzensis, but it pays for many of the other formulations. Then I also put a note here of the other agents, the atomoxetine, that it's covered. And it does cover the Qelbree. So these are just a different form of the similar information. So these are the methylphenidates and amphetamines that are immediate release. Now I crossed out methamphetamine because I think you should not prescribe methamphetamine for your patients. And then you can see that the duration is much shorter than some of the previous formulations we talked about. And then this is the immediate and long-acting release formulations of the methylphenidate. I put X's next to any of the formulations that have to be taken whole because Jack would not be able to swallow them. Any of the others can either be chewed or opened and sprinkled. And again, I cross out the Adzensis because it's not available, and the others are crossed out because they have to be swallowed whole. So how would you treat Jack? Which agent would you use? So Jack is 5 years old. He's a preschooler. So for preschoolers, I would recommend starting with behavioral modifications rather than with a drug. So that is my part 1 of simplifying ADHD treatment. I hope you were able to learn something today, and this would serve as a resource for you. Thank you.